Hi, this is John Kanellopoulos from our center here in Athens, Greece. Very pleased to share with you a very interesting case. This is a young gentleman that we had evaluated several years ago with a diagnosis of keratoconus. So he is here. These are his Pentacamps. It certainly looks a little bit suspicious on the right eye. The fact that the cornea is thinning, quite thin here. On surface curvature, the sagittal curvature, it's almost a regular astigmatic picture. Anterior elevation, posterior elevation certainly don't give out keratoconus. The left eye, much more severe pathology, but again, the steepest area of the cone here is not the thinnest area of the cornea. So this is when, we've talked about this before, we have to suspect something different. If we look at each exam separate, this is just the left placido topography, fine. There's a truncation of the astigmatism. There's some scissoring of the astigmatism. It's not in a straight line. It's kind of curved. If we look at the right placido, we can see more of that scissoring here and the truncation of the astigmatism. And again, these alone may suggest and may make us suspicious that the patient may have keratoconus, but the pathology here is different. There's some severe corneal opacification here. It almost looks like a limbo stem cell deficiency, some inflammatory disorder that we were never able to define. This is right eye, this is the worst left eye. See how deep and how broad within the cornea. There's neovascularization here. This pathology reaches. What level does it reach? We started with topical steroids and topical cyclosporin A, these are some of the images on anterior segment OCT, the Avanti, OptaView sections, seeing how dramatic the changes were. If we look into the peripheral cornea here, the significant superior edema on the left eye, and if we go and look at similar images here, the epithelium has changed and the cornea is very almost infiltrated, very deep, and has a response with vessels. Where the right eye is a little bit more subtle, there's less of that infiltration here, less response of the epithelium, and the cornea thickness, of course, is normal, something that does exclude the diagnosis of keratoconus. So now if we go at today's pictures, we're almost 4 years out. Again, the topographies may look suspicious. This is a right eye, the truncation has improved a little bit, and as this is more broad, and the scissoring has improved a little bit in the placido disc topography. Truncation exists, maybe a little worse in the left eye, but the scissoring has improved. And if we look at the anterior segment OCT, we can see the dramatic improvement from last year, 2020, to today, how the epithelium has almost normalized and much more dramatic if we go back and look at those images that we saw before from 2017. Same thing with the left eye, a lot of corneal irregularity, a lot of blue in here in the epithelium, where now it's almost more uniform as far as no blue. Again, the corneal thickness has changed dramatically because of the epithelial changes. And more importantly, if you go to compare, that peripheral infiltration has improved. And these are comparisons with last year where the patient had responded well. And this is again last year to this year. And of course, last, the clarity of the cornea here in the right eye and left eye, all the vessels are gone and the infiltrate is almost gone. So not everything that looks like keratoconus is keratoconus. Here we see a nice response with topical steroids and topical long-term cyclosporin treatment. You can see how brisk the reflex is from the cornea. A success story. And the question arises, how will we treat this patient, treat his refractive error? His refractive error is quite significant. He carries the significant refractive error right now, -2 in the right eye at 20 degrees and -3.5, -425 in the left eye at 173 degrees. Best corrected 20/20 plus in the right eye, 20/80 in the left eye. And what will we do to treat this patient and whether he's stable enough to be treated at this point? So question arises, PRK, LASIK, wait and treat the anterior segment disease more. I will leave you with that question, and thank you for your attention and following with me another case of Keratoconus Grand Rounds. Thanks so much.